Hello, I'm Janice Karen, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. Next slide, please. So the first update is that the fairly long-awaited TEFCA Common Agreement version 2 was formally released on Monday. We've already talked about this agreement in some detail and some of the upcoming TEFCA changes, so I'm not going to go into an excruciating amount of detail, but just to review what some of the big changes are. Common Agreement version 2 includes support for facilitated fire between participants and sub-participants. Basically, that means that you can use TEFCA for the to look up the endpoint directory and then do your fire thing from there with underneath the agreements that are part of TEFCA. They also moved a lot of specific requirements from the common agreement into the various standard operating procedures so that they're in the place where they most apply. They also made more consistent terms of participation. Under previous versions of the common agreement, there were guidelines and frameworks for what the terms of participation should be, but each QHIN was able to make their own. Now they're standardized across all of the QHINs. There's also a new healthcare operations sub procedure 1, which is for quality measure data exchange. And if you're using a fire, you must respond to it. There's also the introduction of principal and delegate roles. We've talked about that several times, where delegates allow someone to act on behalf of someone else within the TEFCA environment. And then one of the bigger changes, which is also helpful when you're talking about principals and delegates, is that participants and sub-participants can use more than one QHIN. In previous agreements, you signed up with one QHIN and you had to use that QHIN for everything that you did within TEFCA. So you can find some information at the first link and the new common agreement at the second link. It is also going to be in the Federal Register. They are required. Most of the TEFCA documents do not go into the Federal Register, but the common agreement will be there. And so as far as I can tell, that has not happened yet, but this is the final version. So any questions, comments, thoughts there? And XP stands for exchange purpose. I just blanked out on that for some reason. All right, let's move on then. All right, so OCR has released the final version of the reproductive health privacy rule that we reviewed about a year ago. Just as a reminder, some of the key components are that it disallows the use of PHI for any type of criminal, civil, or administrative investigative or purpose, or to assign liability to people related to any aspect of reproductive health care, as long as that care is legal within the environment in which it was given. So, for instance, to pick a not so hypothetical example, if someone were to cross state lines to get an abortion, and the abortion is legal in the place where they get the abortion, the people who provide the abortion are not allowed to release PHI to investigators from the place where the abortion was made illegal. And they're also not allowed to identify the people who were involved in that procedure, including the person who got the care. And so those prohibitions apply to anyone, any covered entity or business associate, as long as the healthcare that was provided was legal under the circumstances under which it was provided, or that it's protected or authorized by either federal law or the Constitution, regardless of where it's provided. So there's a fact sheet that links to, I'm sorry, there's a press release that links to a fact sheet and the rule itself in the Federal Register that I've linked to below. But any questions or thoughts or comments about this rule? Excuse me. All right, then let's move on. So this will be a multi-slide update, hence no link at the bottom. CMS has put out an update to its national quality strategy. And there are basically 4 priority areas, each of which has 2 goals. So there's 8 areas that it's focusing on. And this is just basically an overview of each of those 8 areas and what they're looking to do in those 8 areas at a very high level. And then you can look at the document, which is linked on the last slide, for more specifics and to get into more detail. So the first priority is called outcomes and alignment. So each priority has goals, and they literally just put the goals together. So it's goal 1 and goal 2 is the name of the priority area. I don't know why they decided to organize it that way rather than just have 8 goals, but or 8 priority areas, but they did what they did. So under outcomes, which is goal 1 of outcomes and alignment, they're looking to drive improvements everywhere, but they're particularly focusing on behavioral health, maternal health, long-term services and supports, and dental health. Dental health is interesting because it hasn't necessarily been something that's been mentioned as a huge priority, but there have been more and more rules and guidance things. So it definitely has become a priority kind of under the covers. And this is the first time that I remember them mentioning it explicitly as a priority. So that's something to look for. And something that my guess is that we'll see more of as time goes on. They're also looking to use quality measures, not just to improve outcomes, but also to drive value-based care and reduce provider burden. And on the surface of it, reducing provider burden might sound like, under the context of quality measures, might seem like a little bit of an oxymoron, because dealing with quality measures is a bit of a burden. But the idea is, we'll get to later, but part of that idea is to sort of is under alignment and getting everything aligned so that you're not doing different quality measures for 8 gazillion different people, and the quality measures all have meaning. So I think the idea is that if the quality measures are specifically pinpoint focused on improving outcomes, then it reduces the burden because you're not doing them for all kinds of other things. It's a little bit of an interesting argument. I'm not disagreeing with it, but I still think it's a little bit interesting to point it out at the top level. And then they're also looking to set benchmarks to track progress, and they do an assessment every 3 years to sort of against that benchmark to see how folks are doing. So that's sort of the idea. Those are the goals under outcomes. Any questions there? All right, so under alignment, so we sort of led into this with the last set of comments, but they've been talking about this for a while. I haven't necessarily seen a lot of direct action yet, but hopefully soon. But they're looking to align the measures across different quality programs. And they're also looking to use what they call the Universal Foundation to focus on key clinical areas, plus including specific populations or care settings. But I would also look at those key clinical areas. I would jump back up to outcomes and look at what they were the high priority outcomes. And I would assume that part of what they're going to do is align the measures with those high priority outcomes. They're also looking to streamline the measure development and the way measures are selected, including internal CMS coordination across the different programs. So this is part of the burden reduction would be having different CMS programs have the same or similar requirements around quality measures. So that's one thing they're actively looking to, and they're looking for more industry collaboration. None of these are new. These are all things that I remember going to a CMS webinar probably 18 months ago, where where the point of the webinar was quality measures alignment, where this is exactly what they were talking about. I'm not sure that they're moving as quickly on this as they would like to, but it is something that they have been regularly talking about, at least. So it's on the radar at a minimum. Any questions, thoughts, or comments there? All right, next slide. Priority 2. Equity and engagement. So goal 1 is equity. So here we have ONC's infamous equity by design, which obviously is a good way to do it if you're going to try to do it. And they have a goal of linking payments to performance on quality measures with equity in mind. And then improving the data collection, standardization, and analysis, particularly around race, ethnicity, and SDOH data. So they it's not clear in the overview sections, which is all that I've had a chance to read because this just came out, exactly what they have planned in that area, but they are looking at additional requirements and improvements in those areas. Any questions there? All right, so around engagement, this is a combination of there's a little bit of discussion of industry engagement, but this is actually meant more at an individual level. The individual patients, their families, their caregivers, and sort of the community around them. So they're looking to get more sort of boots on the ground level input into their strategies and policies, and to expand the use of person-reported outcomes and experience measures. And then obviously this one's important to us, give individuals access to their own health data. The patient access API and the provider directory APIs that were introduced in 2020 were obviously a big step in this, but they're continuing activities in that, and the advancements of the patient access API and the new CMS rule, but obviously that continues to be a priority for them. And then also public reporting of quality and safety by individuals, families, and caregivers, and making that so that people can make more informed decisions about their care. So that I thought was interesting. I think that's both allowing people to directly report issues, but also giving them access to the reports in some way so that they can judge where they want to get their care. So any questions, thoughts, or comments there? All right, let's move on to the next set of priorities, the next 2 goals. Safety and resiliency. So for the safety, it's primarily transparency and accountability, and using both incentives and carrots and sticks. But they also put in this section a discussion around safe use and security of EHRs and PHI. So they're underneath safety, they're including both traditional patient safety and data safety, basically, and data protection. So I thought that was interesting and a good sign. And then under resiliency, this is a combination of addressing some of the areas that we know are important, but maybe don't focus on as much ourselves here. Although we do talk about some of the emergency response components, but staffing, infrastructure needs, emergency responses. And what I thought was interesting is that they separated out times of crisis, like the public health emergencies and natural disasters, from climate events, some of which are natural disasters. And so they're specifically addressing climate events separately, and they include things like poor air quality. And so here they're talking about actually, in addition to dealing with the health outcomes of these events, proactive mechanisms they can use to reduce the impact of climate. So I thought that was an interesting thing. It's something that I think is a little bit different. You don't normally think of CMS as a place that you would try to address emissions reduction, but they talk about it here. So, anyone have any comments or thoughts there? All right, well, then let's go on to the last one, which includes interoperability. So, interoperability and scientific advancement. So, here they're talking about, again, nothing new, but pushing standards and technology for interoperability, the transition for digital quality measures, which they've been talking about fairly consistently for 2 years now. But I thought the last one was actually a really promising sign because, as we've talked about here, it's not just the technology. There's a lot of cultural process workflow elements around interoperability. And so they talk about promoting organizational readiness and collaboration, and then leveraging the improvements from greater interoperability. So they talk about in this third bullet, they talk a bit about a lot of the things that we talk about, that the requirements for interoperability are a floor, not a ceiling, and helping people work together and looking to leverage the increased interoperability to do good things, not just meet interoperability minimums. So I thought that was a promising item. And then finally, under scientific advancement, this is where they talk about AI a bit. And so here it's not just, they have a little bit about the review process and making it faster to get research out there, but it's primarily sort of in focusing on improving the data available, both for research and for evidence-based practice. So I thought that was an important thing that they slipped under scientific advancement. So guidelines for evidence-based medicine, things like that, improving those fall here. And then advancing AI, predictive analytics, and other tools like that that may help with decision making. So it's really an interesting document. I have not read it from cover to cover. I think it was about 80 pages long, if I remember correctly. And it just came out. So I will be looking at it in more detail. But the things that it's talking about are interesting, and some of them are things they've been talking about for a while, and some of them are new. So any overall comments, thoughts, or questions about the strategy? All right, then let's move on. All right, this is just a really quick update. We talked about some other Inferno test kits that have been released recently. ONC is making a push to get additional test kits out for Inferno, which is its fire testing tool. And they have just released the PASS test kit. So that's the third step in the prior authorization process. Test kits for the first two steps are under development and in testing and should be available in the future. They didn't put a specific timeline on that. And if they don't go into a lot more detail, but you can find a bit more detail in this blog piece. So any questions or comments or thoughts there? All right, moving on. So ONC has also put out another data brief. These are always interesting. And this one is about primary care access to immunization data. It is 2022 data. And one thing that I thought was interesting is they seem very happy that 58% of primary care physicians report general satisfaction with their electronic access to immunization records via either EHR or portal. I think that's kind of low personally. And in fact, if you look down below the lead, 36% of them were not at all satisfied with it. So to me, that's the place that screams out, we can and should do better. Now, having said that, what was interesting was that 58% reported satisfaction. Just about 40% are using EHRs, and 40% are using portals. I guess if there's no overlap there, that gets us above the 50, even with some overlap, that gets us above the 58%. But because they don't split out the satisfaction between EHR and portal. But still, 22% of PCPs are still using paper or faxing. Boo hiss. That's a high number. That should not be that high. I mean, it should be 0, but it certainly shouldn't be 22%. Now here's another thing that was kind of a little bit weird. I'm not this report had some oddities in it. They're usually really good and really consistent. This one to me wasn't quite as baked as they usually are, because they said that 77% of PCPs viewing external immunization information knew that they were aware that they could view external immunization information via the EHR. So they're doing it, but only 3/4 of the people who are doing it are aware that they're doing it, I guess. 74% of them indicated they were aware that they could report to their state immunization system through their EHR. So there's a bit more. They have all the nice fun graphs and stuff. You could look at the full data brief at the link. But I know this one to me didn't. Normally they're really, really good data that make a lot of sense, that provide insights. And I found myself struggling a bit more to make sense of what the data meant here and what they were trying to convey. So just be aware, if you do look further, that you may have some questions. And if anyone has questions now, I can make a stab at it. All right, then let's move on. So AHRQ has what they call digital healthcare equity framework. So it's designed to help people assess whether their healthcare solutions that use digital technologies are equitable, and it's supposed to help you at every phase of the digital healthcare life cycle. And it's broken up into sort of about how to evaluate 3 different areas. One of them is your patient and community characteristics. So basically understanding the demographics that underlie equity. The next one is your health system characteristics, and then the health IT characteristics. And within those, it looks at 6 key principles. Make sure that any digital technologies involved help ameliorate and not exacerbate inequities, that you try to be person-centered, and that's how you deal with equity, that you look at what each person needs in the process, encourage inclusivity and participation in the creation of digital healthcare solutions, support implementation in diverse settings in ways that make sense for each of those settings, look at the policy and regulatory relevance or impact of solutions. And I guess that's there because so much of the current policy and regulation is aimed at trying to improve health equity, and then focusing on impact and outcomes across those 3 areas that we talked about above. So you can find more information about the framework at the link below. Any questions, comments, or thoughts there? All right, let's move on to the next slide. And if you'll pause there. I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@mahealthdata.org. That email address is also on your screen.